Welcome to Internal Medicine Grand Rounds. We're pleased to have one of our own here today for Grand Rounds. Dr. Fihn is the head of the Division of General Internal Medicine here at the UW and also the director of the VA's Office of Analytics and Business Intelligence. He got his medical degree at St. Louis University School of Medicine before coming here for his internal medicine internship and residency. He picked up an MPH at the UW School of Public Health along the way, and then was a Robert Wood Johnson Clinical Scholar before ascending to the dizzying heights of the UWMC Chief Residency. He's been here since, climbing the ranks, and has been a full professor since 1997. In addition to the work he's been doing here, he's been deeply involved at the Veterans Hospital, including serving as the acting chief of staff there, and in 2005 received the Exemplary Service Award, which is the highest honor bestowed by the Veterans Affairs. He's heavily involved in the Society of General Internal Medicine, amongst other societies, and has received SGIM's Robert Glazer Award in 2012. He's also been the PI or co-PI on an extraordinarily large number of grants focused on the mechanisms of high-value care. He's published more than 225 manuscripts, many textbook chapters, and given the amazing breadth of topics covered in these publications, is also appropriately the lead author on the textbook Outpatient Medicine. He's lectured internationally on multiple topics, including the impact of big data on healthcare, and we're lucky to have him today to talk about big data in healthcare, promise and perils. Dr. Stephan.
Good morning. Thank you. It's a real pleasure to be here. And I want to comment that our leadership from our medical center is here, which is wonderful to see. So what I'd like to do today is talk a little bit about the evolution of analytics within the VA. And lest you think that this is irrelevant, I think in this era of accountable care organizations and consolidation of health systems, whereas the VA was once sort of far and away the largest integrated healthcare system, that's really no longer the case. There's some very large systems now, and I think some of the lessons are applicable to other health systems, including perhaps our own. I'm going to talk about some of the newer stuff we're trying to get done in this environment and perhaps why. Talk a bit about some UW programs, which I think are relevant, and a bit of UW data. And then talk about some of the sort of hazards, and perhaps other systems can learn what we've sort of learned the hard way. I know most people here are familiar with VA. It's a big system, as I suggested. There are about 1,000 sites of care around the country, 152 medical centers, and you can see scattered all over the territorial U.S. So I sort of look at our journey in analytics in three phases, which aren't clearly distinct. But the VA, as many of you know, was an early adopter of the electronic health record back actually in the 90s. Puget Sound was the second facility within the system to beta test our EHR. Many of us used it before actually there was even a graphical interface. It was just a text entry system. So it's been around for a long time, and that's given VA an opportunity to sort of lead in the area of data and electronic records. And during our last near-death experience, I think we're having our second near-death experience at the moment, but during the first one back in the 90s, a lot of changes came in the system, and one of the big ones was the adoption of a performance management system that really was the forerunner of what many of you all and medical centers are very familiar with today. But that was 20 years ago. And as you could see in the original sorts of measures, which ultimately became HEDIS measures, with which we're all familiar, back in 96, our system was pretty abysmal on many of those. And by instituting a performance measurement system, feeding that back, you can see within a relatively short period of time, over a period of 4 or 5 years, performance on those went from the mid-30% up to close to 90%, where it has remained for the last decade and plateaued. And I think that's one of the first points, is we sort of in this first generation of using data, we understood its limits because we got to a certain point beyond which flogging the system for minor improvements really was no longer cost effective. And we found by doing this, by just feeding back these metrics to individuals, people really felt like they needed more data to manage their programs. They felt like they had limited access. They were just seeing dashboards. And the data, of course, were highly filtered in the form of these metrics. And we began to see even the early signs of alert fatigue and information overload, where people were getting bombarded with these metrics on a regular basis, some of which they felt rather helpless to influence. There were other unintended consequences, too, and I won't go through this in great detail, but the top is a study from folks in Ann Arbor who actually looked at the management of hypertension when our metric, wisely, we never got below the 140/80 metric. We didn't go to the 135 metric, which many people adopted. But what we found was, in short, that we were about 12% shy of having complete blood pressure control in our diabetic patients. And you might make the argument that, well, if you just press a little harder, you can get that other 12%. But the countervailing observation was that within that, there were also about 12% of patients who were over-controlled, dangerously so. They were on 3 to 4 drugs. Their diastolic blood pressures were below 60, so that you sort of reached an equipoise where harm and benefit, and perhaps harm had already outweighed benefit. And we saw this again with many other metrics over time, including A1Cs below 7, which we didn't adopt but were adopted elsewhere, and the risk of hypoglycemia, pneumonia, treatment in the ED for 4 hours in which people were getting inappropriate antibiotics, and so forth. The other thing that was in a qualitative study that was observed is that as we began to inundate providers with all of this data and metrics, that it's the old when everything's important, nothing's important. And so things were starting to get lost, and they would find that in amongst all the reminders and drug interaction data and everything that providers were being asked to look at, they were missing key findings, such as abnormal radiographs and things getting lost because there was no real filtering system to prioritize the data coming in. And I think that sort of led to our sort of second, what I would term our second generation, in which we really started building very large, rich data systems. And right now we have a corporate data warehouse in which we, in real time, consolidate the data from across our system. And you can see it's astoundingly large. So that we now have, you can see every day 1 million orders, 1 million images, 3 million images, 1 million text notes, all are being dumped into this system and are essentially available as soon as they appear in that system. So we have really rapid turnaround in data. The downside is it's a very big and complex system. We have nearly 1 trillion rows of data in that, and we have a requirement for pretty sophisticated analysts to manage that data. And we've found by doing that, though, what we can do is provide data back to users in ways that are a bit friendlier than simply the listings of red and green boxes that often go with performance metrics. And it's gotten so large that actually we've had to develop our own Google-like search engine just to find the reports that are generated. So this is one of the web pages from our office that lists reports that people can obtain that we produce. And you can see they span the entire gamut of healthcare operations in our system, from business and capital planning to clinical care, quality and performance, resources, and every one of those that you can click on will generate a list of several reports, which in themselves are multidimensional cubes with drill downs to hospital and actually patient level on most of those reports. And as I said, we have a search engine now called RAMP so people can find things, because the biggest complaint I get is oh, you don't make the data that I need, and actually we do, but nobody can find it. And we've tried, through sophisticated graphics, to provide data to ways that would be more informative. Rudy Rodriguez has probably seen these type of data, which, for example, for specialty care, shows the relationship between productivity and access. So trying to get a bead on how our specialty care staffing is poor access because we're understaffed or because they're just not seeing very many patients. And that's just an example of the kind of output. This is an output for our CAPS data, our patient experience data, which I'll talk more about vis-a-vis UW in a moment. But we actually drill down to question levels, and you can see in the yellow bars, we tell them exactly what items they need to keep where they are in order to maintain their CAPS scores. So in this case, you can see it says at the bottom, providers spend enough time. Well, that's one of the big contributors to the current level of satisfaction. If that were to erode, scores would drop dramatically. On the right side are the things that they could do to improve their CAPS scores. So you can see at the top was after-hours care, so 24/7 access. So we actually try then, instead of giving them just overall scores, to give them some diagnostics about where they can improve. We try and give some summary kinds of displays. This, as you can see, displays 23 different domains of performance measurement. We do each one of these for every medical center every quarter. Rudy has seen these many times. It's called the SAIL report. And this just sort of shows, in this case, you can see with the blue squares toward the center in relation to all other VAs, this particular facility does well with regard to their AMI mortality, wait times, primary care, less well in terms of their pneumonia mortality, lengths of stay, patient satisfaction, et cetera. So it's a diagnostic for high-level management to sort of look at and sort of maybe begin to ask questions about where there may be performance gaps. But at the same time, there's been, again, this enormous proliferation of metrics. This is a figure from the, still in draft form, but about to be released, IOM report on core metrics for health and healthcare. And they make the point that there are just way, way too many metrics out there. And this is a figure. So you can see on the left-hand side, not that you should read it, different concepts. And what they say that there are hundreds of measurement concepts, and that really translates into literally thousands of measures that are being used in various spheres. And they make the point that you absolutely cannot run or manage healthcare systems with that myriad of measurements. And actually are arguing we should go back to a core of 10 or 12 metrics that we really hold ourselves accountable for. And how this plays out in the clinical sphere is, we survey our primary care providers annually about morale and burnout. And right now, about 40-some-odd% of our primary care docs meet criteria for burnout. And if you ask them, what are the items that you think are the greatest barriers to providing quality of care, I've highlighted 3 of them, which all have to do with management of information, that they're spending too much time. It's taking away from what they think is their main job, to take care of patients. And we heard in a grand rounds earlier this year that adopting, Krasinski told us that adopting an EHR adds to a full-time, adds about 90 minutes of time to a provider for every 8 hours of actual scheduled patient care. So now we've kind of moved into what I would think of as our third generation to sort of try and address at least some of these problems. So what I call desktop business intelligence is, in other words, that stop forcing people always to go to pre-populated reports and making them ask for data, but allowing people actually to work with it and manipulate it at their desktop with modern analytic tools. What I sort of think about as the democratization of the data. So it's not always filtered from the top down to the bottom, but people actually throughout the organization can begin to visualize and manipulate and have access to data, and in ways that can display it in usable formats so that if they're involved in process improvement or whatever, they can get to data and not feel like they have to go to the medical director's office and enter a request and sort of get it that way. Two, and I'll talk a bit more about this, is advanced analytics. Because of this mass of raw data, we can't no longer expect everyone to sort of deal with the raw data. We need to process it, and process it in a way that makes it usable for them, both for clinical purposes and for program assessment, so our organizations can know how they're doing. We need to have what's known as platform independence. We need to be able to do this on our phones, on our tablets, on our laptops, wherever we are, given the span of healthcare delivery today. And we need to start thinking about how we apply this to population health, and I'll talk a little bit about that. And importantly, actually putting it into the workflow, because what we're hearing back from the providers is they view all this as parallel to and distracting from their major work. And really, it needs to be part of their work so that it doesn't seem to be distinct. And so this is just an example of the sort of level of the BI that you can people can make tables and graphs, they can do it on their desk, they can click and point at various bars and drill down. It's intuitive, it doesn't require programming skills, and allows an organization to become more fluent in using data. When we talk about process data, what do I mean? I mean data that are analyzed and then presented back, and sometimes in very complex ways. So one of the big challenges of healthcare systems today is how do you manage your highest cost, highest risk patients? We all know, and we've heard multiple times, that about 10 to 15% of patients consume 60 to 70% of the resources in any healthcare system. And who are those patients? How do you manage them? So we were asked by our leadership to try and develop a way that we could identify who those patients are and develop something called a Care Assessment Needs Score, which is a bit euphemistic, but probably seemed better than calling patients high risk. And it just categorizes patients across our system from lowest to highest risk on a percentile 0 to 99%, and how likely they are to die or be hospitalized. The current model we're using has about 120 variables in it. We've actually are in the process of cutting it down to 30 some odd, and you can see they come from a variety of data domains within our system. So demographics, vitals, utilization, diagnoses, lab radiology reports, drugs, and even text notes that allow us to pull these together. And if you look in the literature at most of the predictive models for readmission or for death, they typically have something known as a C statistic, which is a measure of predictive accuracy of about 0.65 to 0.7. What does that mean? Well, C statistic is otherwise known as area under the curve, ranges from 0 to 1.0. 1.0 means it's perfect. It means every prediction is spot on. 0 means every prediction is wrong. And 50.5 is essentially flipping a coin. So if you think about a C statistic of 0.65, that is slightly better than flipping a coin. You can see these models now have C statistics which for some predictions are approaching 0.9. They're tremendously accurate. Why is that? It's because we've got access to clinical data. The earlier models are based largely on insurance and claims data. When you can start pulling clinical data in, prediction gets tremendously better. And you can see these curves just show the observed to expected. So we do a prediction for a year, and then we look and see what actually happened, and you can sort of see the near identical curves that are generated for observed to expected. So this just, lets us know the power of being able to do that. So we condense all those variables into a number that's delivered back to a primary care provider that comes on, and for those who practice at the VA may see this, that ranks your entire panel from top to bottom, from highest risk to lowest risk. Our nurse care managers can now identify the patients at highest risk who might need to receive additional services. And if you go back here in the lower left-hand corner, we can identify some really high-risk patients. So those in the highest percentile have a 72% chance of either being hospitalized or dying in the next year. So they are extraordinarily high risk. And then even here we can tell now what services are these patients getting? Are they in telehealth? Are they in home care? Are they in palliative care? When were they last in the ED? When were they last hospitalized? When were they last in primary care? So we can start looking and saying, is this patient receiving the care coordination services that might be appropriate for someone at this high risk of poor events? Now, the downside is that we actually track use of these scores. Because it's web-based, we get web stats on this. And you can see that on the left-hand graph, we have somewhere about 1,200 individuals who retrieve these scores at least once a month. That's probably an underestimate because there are other ways they can get it. They can download them in batch, or they can have their nurse care managers download them for them. But even so, it sounds like a lot, but we have 7,000 primary care providers. So somewhere only about 20 or 25% of people at max are actually using this information or at least looking at this information. And you can see in terms of hits on our website, it's only about 3,500. Some of our reports get 90,000 hits a month. So, again, I think this was sort of a symptom of the overload that we can provide these data to people, even in a relatively simple format, but they're not actually in their workflow at this point. And, the other thing we're finding is that there's a bit of a mismatch between the services we provide and these high-risk patients. So if you see the bar graphs, there are two pairs here, and the pairs, have patients with a score less than the 95th percentile and a score above the 95th percentile on the right. And so you can see here that of those with scores above the 95th percentile, only about 10% are enrolled in telehealth. Only about 4% are enrolled in home care. Less than 1% are in palliative care or hospice. So, again, when we look at that as a system, we are saying, are we actually matching the resources that we have to the needs of the patients? And, these data now allow us to make sensible or thoughtful strategic decisions. And I'm not arguing that we should say, oh, you've got a high score, you need telehealth. Quite the contrary. I think these need to be filtered through a clinical mindset. But like any lab test or finding, it provides information. So we've now developed a specific application for nurse care managers that allow them outside of the EHR, which really isn't very friendly, for actually managing and coordinating services, that they can then identify these patients, track consults, track services, and manage them that way. Again, we're sort of still evolving to see how we sort of get this kind of information into workflow. We can also geospatially map this and identify for system leaders where the concentrations of our high-risk patients are. So for citing services or programmatic development. And we are able really to do very similar kind of modeling with a variety of targets. So you can see kidney, cardiovascular, ID, mental health. All of these models, which we now have the ability to almost generate automatically, have C statistics in the same range as what I just showed you. They're very accurate. So the problem is, the good news is we can identify patients at high risk. The problem is most of these are still sitting on the shelf because we don't actually know how to implement them and how to get them to the people who need them and what the interventions would be. And that's really the challenge. So it's no longer actually an informatics challenge here. It's really an organizational challenge about how do you integrate these high-level data into a system that providers view as helpful and not as information overload, and link easily to the services which could be beneficial to patients. I'll give you an example. The other thing the system allows us to do is to do some very sophisticated analyses of our programs. And increasingly, as you get these large health systems, managers are asking questions like, what do we get for our investment? And so actually the Secretary of Veteran Affairs, the former Secretary, Eric Shinseki, asked us, we'd spent about $1.5 billion on a patient-centered medical home, and I'll talk about that in a minute. But he asked us the question, he said, what did we get? What was the return on investment? Which is a very reasonable question, particularly when it's taxpayers' money. And so we actually, didn't do this as a randomized controlled trial, but we're able to, look back to 2003, model over time what our experience was with various outcomes, and then project what it would have been had we not implemented a new program. So in this case, you can see it's for ambulatory care, hospitalizations for ambulatory care sensitive conditions. And so in the black line is what we actually observed. So that was, and you can see there's always the spike in hospitalizations every winter. And then in the dotted blue line is our predictive model. So you can see it parallels pretty closely what was observed. And then we extrapolated that out using the model of what we would have expected. PACT is the VA acronym for patient-centered medical homes. And then we looked at the delta, which said we probably avoided about 4% of those admissions by implementing this new primary care system. That was less than, I think, management had hoped for, but still, that's 4% of nearly of about 800,000 or 900,000 hospitalizations a year. So it's a lot of hospitalizations. We actually also then were able to turn that into an ROI, project that out to 2020, and so give management tools to say, what actually was our financial gain or loss on this. You can see when we did this in 2012, it was about a $15 million deficit it was about I'll just go back through. What we projected, initially there was a deficit, but it was only, a couple $100 million. It sounds like a lot, but our budget is $55 billion a year. So in a system of that size, that's probably close to break even, and the care we think improved. So for a net break even with better care, that's still probably a sensible investment. As we looked out through 2019, though, it looked like the investment would be positive over time, which actually influenced them to maintain that investment and keep it and not pull back. We've also asked the question, he asked us, does it work? And I realize this is complicated and I'm moving through things fairly quickly. I'm just trying to give you a flavor for the kinds of things that are possible. So we had to figure out, how do we know if the patient-centered medical home is working? Previously what people had looked at is the HEDIS measures and asked, did the HEDIS measures get better? They did that because those are the measures that we have. But I'd shown you earlier that most systems have topped out their HEDIS measures at about 90%, and you're not going to see much improvement in that domain. And so we actually looked at what the program objectives were. We mapped those to the Institute of Medicine principles of primary care, and then actually went to our data systems and here, looked at our CAHPS scores in our corporate data warehouse, provider surveys, and again, patient surveys, identified items, in there and came up with a composite score that had 53 items in it that we then sort of measured at our 1,000 sites of care. And just quickly, the scores, we looked at how many of each of the domains were in the top quartile versus the bottom quartile, scored those, and then looked at how they compared with outcomes we really cared about. So you can see the clinics in the top quartile in the highest scores had CAPS scores that were an average of 9.3. For those who deal with CAPS scores, and though many of you do not, I assure you will in the near future. You can see at the bottom they were about 7.5. This spread from 9.3 to 7.5 in the realm of hospital management is enormous. It's huge. Hospitals will pay contractors hundreds of thousands of dollars to raise their CAPS scores 0.1 or 0.2. These are gigantic differences here. You can see the overall rating of their providers, big difference. Provider burnout, this is a 5-point scale. The Maslach burnout index, that's a pretty big difference, so much less burnout, and ED visits appreciably less at the higher performing clinics. So this gave us a way to sort of validate that we could tell where places were doing well and weren't, and sort of give them some information about how to improve their care. We also looked at the clinical quality metrics, the HEDIS and other measures, and you can see, again, not to go through them individually, but if they're to the right, that means the places with the higher scores had better performance. The places on the lower scores had better performance, and you can see that there's a tremendous number here on this side. And actually, the differences, though not all of these were statistically significant, about a third to a half were actually statistically significant differences. So it looked like those clinics were also performing better on clinical quality measures. So we've actually now given the system a way to track this, which is a big initiative for our system. The third thing, I talked about platform independence. So moving as much as we can to mobile platforms and not tying these to terminals in the hospital, both for patients and for providers. And then this piece about getting it into workflow. What do I mean by that? How do we get analytics into workflow? This is a system which our cardiologists at the VA know very well. It's called a Cardiac Assessment Reporting and Tracking System, or CART. And essentially, they no longer need to write text notes. They interact with pre-populated screens. They click and point for lesions on cath. And there's automatically a note generated both for pre-cath assessments, for cath, and for PCI. And again, we're generating huge amounts of data in our system by standardizing this across 70 some odd cath labs. You can see we're approaching 1 million separate reports now from caths and PCIs, and nearly 500,000 of these. The data are available immediately when the procedure is complete. They go directly to the chart, and that's allowed us. So there was a lot of resistance to doing this, because prior to this, the cardiologists had just dictated notes. They got transcribed and then appeared in the charts. Usually often the fellows would do that, and then they'd have to be authenticated. So weeks after the procedure, a note would appear, authenticated. Now they're 98% of the time done as the patient leaves the cath lab. They no longer have to dictate. The data are standardized, and it allows us then to integrate a lot of other functions into the system. So we now do device safety monitoring. So what does that mean? Once a month, we send a report to the FDA device surveillance system if anyone reported they had a problem with a device in the cath lab. That's led to 3 recalls so far of devices, because these were signals that the FDA followed up on. We can track medication adherence. A big risk, as those of you know who get stents placed, need to be on clopidogrel. Discharge orders cannot, in some hospitals now, cannot be actuated until there's an indication the pharmacist has given the patient their clopidogrel, so they try to prevent the patients from leaving the hospital without it. We give people bleeding risk assessments, and we're starting to give them, this is where one of our kidney models are working, letting the cardiologist know of the patient's risk of contrast-induced renal injury prior to them giving the contrast, so they can adjust contrast load in the cath lab by knowing that risk. We're now starting to measure appropriateness. So if caths are being done inappropriately and knowing and what normal coronary rates are, we're now have an automated system through interactive voice response IVR for contacting patients 30 days after a procedure to ask how their symptoms are. Any adverse event, serious adverse event, goes automatically to a national peer review and is done within a couple weeks. The systems track radiation exposure for the operators, and then actually we also do asset management. So all the stents, and those little tiny stents cost a whole lot of money, are on RFIDs. So before they put them in, they're just automatically picked up by the system and tracked. And this helps also with device recalls or device problems because they're automatically registered in our system. So once you build a system, you can start adding things to it that then are just part of workflow and add value. And from an academic standpoint, this is a great platform for research. These are just the papers in the last few months that the group in cardiology has generated using this system. Which brings us then to sort of how do we start to get these data into the clinical workflow. I know many of you here are Epic users. Those of us at the VA who are Vista CPRS users, this is the home page for Vista. It's the same for every patient. It's mostly populated with data that I don't need to see. That doesn't make any sense. In this era, particularly for us non-proceduralists, most of us really have become information managers. That is our job, to take the information available from multiple sources, piece it together, put it into a cogent sort of plan, and do that. And that's becoming increasingly difficult. And I think we all talk about what we don't like about our EHRs, but at the end of the day, I think it is that it's ill-suited to that task. It doesn't make that task easier. And it's particularly, I think, annoying because, I'll come back, but here's the order set that we get. It's the same order set I had when I was a resident. The only difference now is it's electronic. It used to be on paper, checked. It's the same for every patient. Does that make sense? What we're doing now is we're trying to develop some context-sensitive orders. So we've gone through our big data, 30 million records worth over the last 20 years, and asked the questions of, for an individual condition, what did people order? And try to develop context-sensitive order sets. Does that sound familiar? So it would look something, so it would look something like this for a patient with epigastric pain. This doesn't mean these are not guideline-driven. They're just basically saying, here's, in similar circumstances, what other people ordered. Does that sound familiar? We're accustomed to it. We have that kind of assistance in almost all phases of our non-work lives. We can find stuff. We can search for it. We can get help. The systems know who we are. They know what we've done. Our healthcare systems don't do that. And I think that's adding to the frustration, is there's so much data and our systems are not helping us do that. And there's yet another problem, and I'll deal with that quickly, but I think one that's going to face all health systems in the near future. And that's the issue of, we're being increasingly held accountable for the health of our patients. We're not any longer being paid for individual services delivered, but held accountable for high-level outcomes. And increasingly, those outcomes are, going to be things like overall health of patients. And one of the problems with that sort of approach, and why I think hospitals, as currently configured, rightly object, is that if you look at health, medical care, healthcare represents a relatively small contributor to overall health. The other factors you look at here, particularly social and sociodemographic characteristics, have more to do with health than actually the health care that we deliver, which is perhaps not widely appreciated in the healthcare sector, but it's been repeatedly shown to be the case. And if it is our goal to try and influence overall health, then we have to sort of reconceptualize what we do. So, we've often thought of public health as managing, sort of the programs that do infectious disease control and so forth, and we've thought of ourselves on the right side as the deliverers of clinical medicine and the management of disease. But really what I think the goal is, and accountable health organizations are going to be held accountable for, is the notion of managing the health of populations. And that has to do, sort of my own sort of take on that is maintaining and improving the health and reducing the health risks of individuals and groups in accordance with their preferences. And so that's going to take a, sort of reconceptualization of what we do. That will be a long-term sort of plan as health systems evolve. We've begun to think about that in the VA. The VA is a little different because we've got mandates to sort of do some of those other things. So we are a healthcare delivery system, but we're also a system that provides educational benefits, housing benefits, income support, pensions, etc., which do influence those other determinants of health. And you can imagine now when you're running a system like that, if your goal is to sort of improve health, you then would ask, do I better invest these dollars in housing? Do I invest them in, care for coronary disease? Those of us in the VA know we've got a housing first initiative, so it's very hard to deliver medical care to someone who doesn't have an address and doesn't know where they're going to sleep and can't keep track of their medicine. So, does a health system want to start partnering with a housing agency in their community to make sure that patients are housed, because it's going to be a lot cheaper and a lot easier to take care of patients who are not living on the street? So you could sort of think about strategies that health systems are going to begin to sort of adopt, which are really out of our comfort zone in a lot of ways in our competencies. In order to do that, also, we need data systems. And the data systems I've actually shown you, as impressive as they are, really don't do a good job with that. They're really built around encounters and not to develop longitudinal pictures of patients and groups. And so we really need the ability to characterize groups of patients over time and actually to predict health trends so that we can modify risks. Just as an example, we decided to sort of test obesity and identified, several hundred data points that we'd want if we were going to take a population approach to obesity. We've looked at all the national data sets, both commercial and publicly available, and then mapped them to these terms to try and say, well, if we were going to do this, where would we get data? How would we build a data set that looks like that? When we do that, it allows us to predict trends, so we can now sort of look at our system. And when I show this to the executives in our healthcare system, their jaws drop. They sort of say, oh my God, look at that. That's, our projections for obesity in our system over the next several years. And so that may influence sort of what you think about if you're planning for a health system. We're also trying to sort of look at things differently. So asking questions sort of, if we look at disability-adjusted life years, what are the major contributors? If your goal was to reduce disability in your health system, what are the conditions which are contributing to it? And actually, what are the risk factors? So if you were to sort of then take an investment strategy and say, where do we have interventions that could influence those and sort of begin to make rational decisions? So that brings us to our home turf here. And as many of you know, we are now part of an ACO with Boeing. And that began in this calendar year. I'm not going to sort of dive into the details. Maybe DC Dugdale one of these days. I know DC's out of town today and couldn't be here, but can talk to you about, sort of the mechanics of our accountable care organization. But I think it's fair to say that the Boeing engagement is really the beginning of a much larger effort in our health system to sort of begin to play in this field. And you can see it's not a huge number of patients right now. It's a bit over 9,000 designated patients. There will also be some attributed patients who will be added in later. In other words, patients who didn't designate our system but are assigned to us because of their utilization patterns. And we bear risk. So this isn't sending somebody a bill and getting payment. This is taking a bundled or capitated payment for a group of patients and trying to survive within that. And the amount of money is actually dependent to some extent on our performance. There's something known as shared savings. So there's a basic, we can actually get a bit of a bonus if we do things very well. That's based on service quality, such as access, patient experience, and clinical quality measures, all things which I've been showing you. So access measures, CAHPS scores, and these clinical quality measures, which many of you know. And so increasingly, we're all going to be seeing these kinds of numbers because the financial health of our system is going to be dependent upon those. And so just to give you an insight as to what some of these look like, you'll need to, 95% of the time, these are the access standards that we've agreed to meet. And there will be surveys of patients regularly to ask them whether or not they feel we meet these standards, as well as measuring what actual access is. Patient experience, again, this is what's known as top box, or most of these CAHPS measures are scaled on a 1 to 5 point system. Top box means you get a 5. It's like when you get your car in and they send you that, take it in, and they ask you, if you can't rate us as excellent, please let us know, because they're under top box scoring. And I won't go into it, but there's actually a strong statistical reason why top box is right. There's a big difference in willingness to recommend, for example, between people who give you a top box score, and which is all of the time, versus most of the time, which is a 4. Their loyalty to your health system is very different. So again, the private sector is sort of lagging about 10 to 15 years behind what the VA system has been, but you're going to sort of begin to see just the similar kinds of data on a regular basis that our providers have said is inundating them. Here's some actual data from, I'm going to brag a little bit. This is the General Internal Medicine Clinic at UWMC Roosevelt. These are the willingness to recommend CAHPS ratings over a year's period. You can see they're the second highest in our system and place us in top 4% nationwide. But every clinic is going to start to see data that look like these and have to sort of then begin to think about and have the data that do it. And as systems get larger and data are shared among systems, all the kinds of things I've been describing to you are going to become increasingly prevalent in the lives of all healthcare providers. And again, we've agreed to targets for these clinical measures, both for our designated and attributed patients. And you can see some of them we're not doing real well on right now, such as, for example, depression follow-up. Which is we've agreed to targets over here, and here's where we are, or depression assessment. So many of us are going to find, sort of people coming to us with, increasing expectations for these kinds of performance. Soon we will probably be in an HMO that's at least, an ACO, which is at least 5 times the size of the Boeing one with the healthcare authority. This is the Washington State measure set, and it's growing as we speak. So again, the experience in the VA, I think, will be relevant to what's happening in other healthcare systems, because ours is not very different from those around the country, which are increasingly engaging. And I didn't even talk about the other sources of data which will be inundating us. The EHR and those performance data are actually going shortly to be probably the smallest contribution of data that we have to deal with. Every device now that anyone puts their hands on, medical device, otherwise, talks back. ICU systems. Even we send people out with CPAP machines that report regularly. All of these data, there's an expectation that as people get all of these devices and that patients can use the web portals and patient assessment tools and all that, essentially, we're about to be, drowned in data. And, our systems are, relatively unprepared for this, I would argue. There are a lot of issues that we need to deal with, that even with all these data, we may not actually find the key data we're looking for. As I said, it's not part of workflow. It's often unstructured and hard to get. There's no consistent coding. There's non-interoperability, and the data are often inconsistent. Another problem is just human brains. Kahneman and Tversky got a Nobel Prize for, basically careers that taught us that we can't think rationally. We don't. And I won't go through all these, but there are lots of well-documented biases that smart people, you and I, have these biases. They're wired in. We think we're, able to deal with these data and probabilities, but we're not. We're not very good at it. And computers actually do a better job. And then, there's just all these problems I've sort of alluded to with measurement. That, the strategy of simply measuring and feeding back, has a lot of disadvantages to it that, people are suspicious and they get burnt out and they get tired and they game. And that's the one I'm not going to spend a lot of time. I worry most about. We've had our problems in the VA. The scheduling, many of you read about the scheduling where unrealistic expectations were placed and people behaved in less than optimal way. This is a generalizable phenomenon for those who followed the business in Atlanta with No Child Left Behind and the teachers and the grades. If you look at this one that just came out a couple weeks ago, which I thought was stunning. This is a report from the Army about the Army entitled Lying to Ourselves. And just again, talked about the fact that they'd placed so many unrealistic expectations that it became a relative way of doing business that people just sort of fudged. And fudging became ever more serious. And that, I think as we sort of think through how we use data and how we feed it back, it's got to be in a way that people view as helpful and not as just layer upon layer of, essentially unrealistic expectations. So, in short, I think, as a data guy, I argue we really need robust data systems that link widely in our systems and allow us to do that. We need to integrate the data into the work, and that's a lot, that's hard and thoughtful. And we need good governance, good leadership from our organizations, which is probably more important, actually, than any of the data systems, that sort of sets out the standards and uses the data wisely in our system for outcomes that are really what we want to achieve and are thoughtful. And so I know I covered a lot of stuff, but I can take a few questions if that's...
Great.
relevant and very powerful information. About 2 years ago, Bill Brenner had Christine Castle here talking about choosing wisely, which is, I think, the Dogburn doctrine that we'll be looking at. It seems like there's a good linkage between what is the work that's done there and choosing wisely. I don't know if you
Sure. So, yeah, so again, we could talk about the specifics of the Choosing Wisely campaign itself, but the general principle of, Don, we had, Bill will remind me, our friend from CMS who worked with Don Berwick, who essentially gave us a talk 2 years ago that suggests about 30% of our healthcare expenditures are waste. And the biggest part of waste is unnecessary. Glenn Hackberg. Yeah, and so that gets to the choosing wisely. For instance, I showed you the appropriateness in the cath thing. So we're now trying to tell people before they do a cath, they have to put in why they're doing it, and then we don't tell them they can't do it, but we'll ask them, this doesn't meet any of the appropriateness criteria. Can you justify? Why would you do it in someone who is stable, not having chest pain, not having acute coronary syndromes? Why would you do a cath in this person? And I think, radiology, the same. Why are you getting an MRI? This person had a normal CT scan, 3 weeks ago. We can build, these systems do allow us to do that, but it has to be context sensitive. It has to know the provider. It has to know something about the patient, the clinical data, and it has to be filtered. We have recommendations for antimicrobial stewardship that, if you order an advanced antibiotic for a relatively simple infection, you'll get an alert that says, why are you ordering this? This is not first line. Well, we give the same alert to a third-year medical student that we give to the chief of infectious disease. Our system knows who those people are. Why would we do that? We can also look back at even about what their antibiotic prescribing history is and said, this person almost always prescribes appropriately, or this is a person who typically prescribes inappropriately. We have all that information in our systems, and we actually don't use it. Eric.
Steve, how do you prevent gaming of the system?
You can't. Okay? Any system can be gamed. In fact, one of the comments about healthcare financing that I really like from a senior healthcare executive once said, the 3 worst ways to pay for medical care are fee-for-service, capitation, and salary. So you build hybrid systems that try to minimize it with a recognition that there will be. I think, what you really, at some point there has to be trust in the system, and I think what the Army showed is that, if you're just thoughtless and piling on, the gaming sometimes is, intentionally sort of about, making money, but many times I think it's sort of avoiding pain. People will click a box just because, they may not agree with it. They may, and we had a lot of people who were clicking a box for prostate screening when they really didn't, but to not click that box made your life unhappy. There wasn't even a profit motive there. I think it just requires thought and recognition and surveillance and concentrating on what's important. I think at the end of the day, the most important thing is to identify what is important and focus your energies there and track those things.